Hello, everybody. I'm going to talk about a patient that we have last year in my hospital in Buenos Aires. He was 37 years old, HIV negative, hypertensive, a butcher from Jujuy, that is a province in the north of the country.
Sorry, hang on. Sorry, Astrid, but your slides aren't forwarding, aren't progressing.
Oh, I don't know what is the problem.
You may have to click on each of them as you go along.
Okay, perfect. Wow. Well, it was a 37 years old patient, HIV negative, and he was born in the north of the country and was admitted with complaining of skin lesions. In the beginning, when I saw the patient, he had 3 ulcers with crusty borders and a generalized erythematous rash. And the important finding in the laboratory was the white cell counts, more than 29, a high CRP, and the syphilis serology was negative. Well, in the CT chest, we can see nodular lesions in the left lung. And following steroids and antihistamines, he was readmitted 1 week later with worsening in the general condition and worsening of the skin lesions. And also he presented with chest pain and dyspnea. And well, we can see the pictures, and he has some lesions compatible with purpura. And in the new CT chest, that well, it's difficult to see all the pictures now, but we can see how the nodules now change to cavitated lesions. So he was admitted to ID, and now in the physical examination, we notice lower limb weakness and difficulty walking. In the further investigation, all the viral serologies were negative, and the histoplasmosis IgG was negative also. And in the skin biopsy, they describe a dermal lymphocytic infiltration with epidermotropism, and it was compatible with CD4 T-cell lymphoma. And we can see in the picture the immunohistochemistry with the CD4 positive. In the beginning, we initiate vancomycin plus ceftriaxone, but we stop once we have the blood cultures negative and the biopsy compatible with lymphoma. So, now it's a problem, but well, we have a patient with the cutaneous T lymphoma with nodules in the lungs, with difficulty walking, and the epidemiology was compatible because he was born in the north of the country. So the question was if it could be HTLV positive, and the result was positive. The first test was a chemioluminescence, that is the test for the screening, but we have to confirm this result with a line immunoassay. And the third step is a real-time quantitative PCR to take the proviral load. That is an important factor to the prognosis. So I prepare a little review about HTLV-1 and 2. Now we know that 3 and 4 exist, but the clinical significance is still uncertain. So well, those virus was described the first time by Robert Gallo in an Afro-American patient with cutaneous TC lymphoma. It's a delta retrovirus. The virus has a particular preference for CD4 and CD8 lymphocytes, respectively, and the effects it produces on infected cells are the genome integration, latency, and transformation of the cells, and clonal expansion of affected lymphocytes. The routes of transmission is the sexual transmission, that male to female transmission is 60 times more common. That's why the disease is more frequent in women. The parenteral transmission by transfusion and between IV drug users. Another way is the transplant, the zoonotic transmission, and for me the most important is the vertical transmission, because we have high evidence between 15 and 30% of transmission with prolonged breastfeeding, and only 3% without breastfeeding. That we can see in the graphic, so important, is a key factor in the transmission of the virus, the duration of breastfeeding. And it's related to the transmission through infected cells, is more important than the free viral particles in plasma. So the epidemiology of HTLV-1, the highly endemic areas are the south of Japan, some countries in sub-Saharan Africa, the Caribbean region, and in Latin America, Brazil, Bolivia, Peru, Chile, and also Argentina. And we have more than 10 million people infected worldwide. In Argentina, we have a low seroprevalence, but the problem is in the north of the country, because in the northwest, we have 1% of seroprevalence, and all the patients are positive for HTLV-1 that is related with some pathologies that we are going to talk later. And it's related with original populations in the country. And that point is important because the breastfeeding is more popular to be prolonged in this population, more than in the rest of the country. So the clinical manifestations for HTLV-1, between 1 and 5% of the infected people present throughout life with adult lymphoma or HTLV-1 associated myelopathy or tropical spastic paraparesis, that is the same pathology. Also, HTLV-1 can produce uveitis, infective dermatitis, and is related with TB and Stercoralis infection. And with HTLV-2, we know that it's related with some neurological syndromes and increases the risk of infections, but there is not a specific pathology. Well, now I'm going to talk a little about the myelopathy, because I know that you are interested in that part. It's a demyelinating syndrome with cellular destruction and inflammation in the central nervous system. The risk factors are the age, is more frequent in adults, female, blood transfusion and transplant as the route of transmission, and a high proviral load, higher than 1% in peripheral mononuclear cells, is the strongest predictor of developing the myelopathy. The incubation period is different for the sexual or vertical transmission, is between 15 and 20 years, but evolve quickly if the virus was transmitted by transfusion. The clinical presentation is basically pyramidal and autonomic syndrome with progressive lower limb weakness until spastic paraparesis with hyperreflexia, clonus, and Babinski sign positive with neurogenic bladder or constipation and deep sensitivity disturbance. The pathophysiology, well, is complicated and is not completely understood, but we have three theories or mechanisms involved. the autoimmune mechanism, the pro-inflammatory disorder, and the clonal expansion of lymphocytes with neurotropism. The patient have perivascular lesions and parenchymal lymphocytic infiltration, and we can see macroscopic change as loss of spinal cord volume. TAX protein is related in the pathophysiology. It's an important protein that stimulates the TC proliferation and avoid apoptosis. 50% of infected people have antibodies against TAX protein, and higher levels are related with higher proviral load and development of the myelopathy. And also the virus induces a pro-inflammatory T helper 1 state in CCR4 and CD4 T cells from blood and CNS. Well, we have the criteria for the diagnosis in the first part of the slide that it's impossible to see now, but to define the pathology, we have to see a patient with a non-remitting progressive spastic paraparesis with sensory symptoms can be present, but without a clear-cut sensory level. And urinary and anal sphincter signs or symptoms can be present. And obviously we have we need the positive serology in blood or in CSF, and this test can have to be confirmed with the Western blot or the line immunoassay. And we have to sorry. And in the image, we can see in the MRI an atrophic spinal cord, which express the loss of motor axons, and in the brain, in the FLAIR sequence, we can see subcortical hyperintensity areas with non-contrast enhancing. Well, and about the evolution of the disease, I found two interesting articles. The first article is a 14-year follow-up study with 132 patients in Martinique Island, and they divided the patients in 4 groups. The first group, those patients who require unilateral help, like a walking stick, and that happened 6 years after the diagnosis. The second group was those patients who require bilateral help, and was 13 years since the diagnostic. The third group was the patient with wheelchair confinement, and it happened 20 years after the diagnosis. And the fourth group of patients were death related to the disease, and 25% of the patient death in 20 years because of this pathology. And this article also speaks about the proviral load as an important prognostic factor. In the second article is a 10 years follow-up in 121 patients in Chile, and 70% of the patients begin the pathology with difficulty walking. Only 9% presented with neurogenic bladder. 33% of the patients with pleocytosis in the CSF, around 10 cells. And in the MRI with atrophic spinal cord, 5 years after the diagnosis. Well, our little experience at Muñiz Hospital, we examined 124 patients in the last 5 years. Most of them came from blood bank, and the other patients were symptomatic patients, their relatives and the descendants. We can confirm the diagnostics in 46 patients. Most of them positive for HTLV-1. 29 were false positive from blood bank. That's why it's so important to confirm the serology. And in the first examination, only 24% of the patients were symptomatic, 7 of them with the myelopathy or the tropical spastic paraparesis. Around 60% of the patients HTLV-1 positive were born in endemic areas, the countries or another countries. And we find more than 50% of positivity between couples. Well, and about the treatment, it's complicated because there aren't a specific treatment for the pathology. And we know that some drugs as tenofovir, sidobudin, lamivudine, and integrase inhibitors has an important in vitro activity against HTLV-1, but in the last trial was a clinical trial of raltegravir, did not have any impact on the proviral load in this cohort of patients. And clinically, all patients' neurological scores and objective measurements remain stable. So only a subset of patients had a mild decrease in proviral load. Now ARBs plus steroids are being evaluated in rapid progression myelopathies. And the results around the corticosteroids are controversial because the recommendation is in patients with a progressive disease, but the evidence is low. It's an expert panel support and have been reported in some case series to a slow progression, reduce neurologic disability, and improve pain. But other studies have reported not so much benefit, and we don't have a randomized clinical trials yet with corticosteroids. Well, but we have the symptomatic treatment that is very important because we have to improve the quality of life of these patients, and we can treat the spasticity with baclofen or botulinum toxin injections. We can offer treatment for the neurogenic bladder with oxybutynin or another drugs. We can treat and prevent the urinary tract infections and change the diet to the constipation and treat the neuropathic pain with gabapentin or antidepressants. And well, it's important the physical therapy for the general motor disabilities. Well, the only treatment that has more evidence is sidobudin, chemotherapy, and interferon, but it's for the T lymphoma. It's not for the myelopathy. So the clinical suspicion is important in patients with compatible epidemiology and clinic. This pathology requires multidisciplinary work, taking into account the advice and support of the patient and their family. The screening in selected patients can prevent new infections with special attention to the use of condoms in serodiscordant couples and avoiding the breastfeeding. And obviously more randomized studies are needed to evaluate the efficacy of possible treatments. So that's all. Thank you.
Thanks very much.
Sorry for the presentation. I don't know what happened with the PowerPoint.
You don't need to be sorry at all. It's nothing, you've done nothing wrong. Thank you so much. A really beautiful presentation. For our urology colleagues, this was a bit of a, I guess, a bit of a lateral step because you're going to be asking whether or not this patient actually had a spastic paraparesis. So Astrid, do you want to put them out of their misery?
So, well, we saw few patients in the hospital, but well, I think that is really important, the suspicion of the pathology when we have a patient with the clinic, the epidemiology, well, it's important to prevent more infections.
Okay, so the answer was no. The patient didn't actually have a ham or TSP, but I mean that was what that initial question about.
Sorry,
about
the
difficulty in walking.
Yes, but when the patient was admitted, he was really weak about the lymphoma, and I think was only that and not the myelopathy, and we couldn't continue following up the patient because he was referred to another hospital for the chemotherapy, and he died 2 months later. So we don't know what happened with the neurological signs.
But I believe you have a clinic in your hospital specifically for these patients. Is that right?
Yes. Yes.
Okay, so you have quite an experience.
Yes.
So from our neurology colleagues, just comments around HTLV-1 tropical spastic paraparesis, or HAM if you prefer. How often do you see this in South Africa or in Cape Town? Any of our neurology colleagues want to take that on? Suzanne?
Sorry, we were just running to unmute ourselves. It's not common in Cape Town. I saw it a lot in Durban because it's endemic in northern KwaZulu-Natal. And just like Astrid said, is to keep it in mind when you see a patient from a HTLV-1 endemic area. It can actually cause much more than just, you know, HAM TSP. It can cause cranial nerve palsies, peripheral neuropathies, dementia. So, you know, if you have someone with unexplained neurology and the patient coming from that part of South Africa, you should consider the diagnosis and test for it. Just a tip on the difference. So between the myelopathy and HTLV-1 and HIV, which obviously you can get the vacuolar myelopathy, is that typically in HTLV-1, the bladder involvement is early, whereas in HIV-associated vacuolar myelopathy, the bladder involvement is late. So if you've got someone with spastic paraparesis without the sensory level and the MRI is relatively bland looking, and there was early sphincter involvement, just consider the diagnosis. But thank you, Astrid. It was a very nice presentation.
Thanks. So Suzanne, if you can just, as you had experience, I mean, did you ever use antiretrovirals in your patients in KZN?
Well, you know, it was, I trained there and then I left and then I went back there. So in between my training and when I came back, it was kind of, you know, an attempt was made to use it, which apparently didn't work. So what we did continue to do was in ambulatory patients who could still walk to give them a trial of steroids. And, you know, just for a month, maximum of 3 to see if it did improve things or slowed progression. And it did work in some patients, but, you know, statistically speaking, I don't know if it really made a difference, because obviously you're biased to any improvement in symptoms in a patient that wants to get better.
Thanks. So maybe I could ask our virology colleagues to comment. I mean, the incubation period, obviously from blood transfusion or direct inoculation of virus into blood is great, much greater. I mean, HTLV-1 has latency. But what are the sites, and do we know what the stresses that reactivate the virus are? I don't know, Ruan, if you want to, I think you're the only virologist on, if you want to comment.
So I don't know about stresses, but from what I have read on the topic in various lectures and so on, it seems to be more a interplay between the host immunological status like HLA type and so on that determines a immunological set point of control, and then that kind of determines the rate of progression and what type of pathology you're going to have, rather than discrete episodes of stresses. But I mean, it's not exactly very well known, but I think that's more rather than reactivation. And I mean, incubation period is very difficult to establish because it doesn't typically have a viral syndrome. It presents generally with complications of the infection rather than with an acute syndrome like you would have like a HIV seroconversion illness. So I mean, I don't know if that really answers the question.
Thanks. And Astrid, you mentioned the tax protein. I mean, I take it that's a marker of, again, of the amount of viral replication, because is that not related to the reactivation of the virus? Astrid?
Yes. Well, the tax protein is one of the most important protein of the virus. The effect in the cell is like a transformation of the cycle in the cell. Well, it's difficult to explain, but the patients, only 50% of the patients in that study has antibodies against this protein, and the patient who has higher levels of these antibodies has more risk for the myelopathy.